Yes. So I think people are still joining, but we should start. It's already 4:04. So welcome to all the participants joining us today for this special World Diabetes Day webinar. And as we mark this important day dedicated to diabetes awareness and education, we are pleased to focus on the topic, which is understanding the ocular manifestations of diabetes. So, diabetes is not only a systemic condition affecting blood sugar levels, it is also one of the leading causes of preventable vision impairment and blindness worldwide. So many individuals who are living with diabetes are unaware of the silent yet progressive effects of the diabetes, which we actually have it on eyes, and conditions such as diabetic retinopathy, diabetic macular edema, cataract. So they can develop slowly and often without early symptoms, making awareness and routine eye screenings absolutely essential. So today's session is basically designed to shed light on how diabetes impacts the visual system, the warning signs to look out for, and the importance of early detection. Being an optometrist and a primary healthcare, we should be able to do the early detection, and the latest. We should know the latest approaches in management and treatment. So I would like to welcome Dr. Amok Joshi, our esteemed speaker for today's session, who will help us understand not only the science behind these conditions, but also practical steps for prevention and long-term eye health. So Dr. Amog completed his MBBS at MGM Medical College, Aurangabad. He completed his post graduation in ophthalmology at Nandadeep Eye Institute, Sangli, under the guidance of renowned ophthalmic surgeon Dr. Saurabh Patwardhan. After post graduation, he did a short fellowship in cornea from HV Desai Eye Hospital, Pune. His next fellowship was in cataract phacosurgery at Nandadeep Eye Institute. After that, he did a long fellowship in medical retina at Dr. Agarwal's Eye Hospital, Pune, under the guidance of renowned vitreoretina surgeon Dr. Nitin Prabhudesai. He has experience of working in rural areas where he created awareness about diabetic retinopathy, and he has conducted many eye checkup camps. Dr. Amog is also a renowned Indian classical vocalist and has performed many concerts across India and abroad also. So, welcome, Dr. Amog. Uh, the session we are handing over to you.
Yes, thank you so much. I'll just share my screen. Okay, am I audible?
Yes, yes, perfectly fine.
Yeah. So good afternoon, everyone. Today, on the occasion of World Diabetes Day, it's a pleasure to be here and to speak about topic that holds such great importance, that the ocular manifestation of diabetic mellitus. I would like to begin by thanking the Optometrist Federation of India for organizing this educational session and for inviting me to be part of it. Their continued efforts in spreading awareness and promoting professional education play a vital role in improving diabetic eye care across our country. As you all know, diabetes doesn't just affect blood sugar, it affects almost every tissue in the body, including the eyes. In fact, the eye is one of the most sensitive organs to the effect of diabetes. And many patients come to us with visual problems long before other complications are discovered. By the end of this session, I hope you will have a clear understanding of how diabetes affects the eye, how to detect these changes early, and how we can manage or prevent vision loss in diabetic patients. So let's begin with a brief overview of what diabetes mellitus actually is. Diabetes is a heterogeneous metabolic disorder characterized by chronic hyperglycemia, meaning persistently high blood sugar levels. This happens because of problems in insulin secretion, insulin action, or both. As a result, there are disturbances in the metabolism of carbohydrates, fats, and proteins. Over time, this chronic hyperglycemia leads to structural and functional damage in many organs, especially the eyes, kidneys, nerves, and blood vessels. So, in simple terms, it is not just related with sugar, it is related with blood vessels and metabolism. And that's why we see such a wide variety of complications. So there are many classifications of diabetes, but broadly it is classified into type 1 diabetes, type 2 diabetes. Type 1 diabetes is also known as insulin dependent or juvenile onset diabetes, results from autoimmune destruction of pancreatic beta cells leading to an absolute deficiency of insulin. These patients usually require lifelong insulin therapy. Type 2 diabetes is the more common form, what we often call adult onset or non-insulin dependent diabetes. Here, the problem is not a total lack of insulin, but rather insulin resistance or a defect in secretion. Lifestyle factors like obesity and inactivity plays a major role in this type. So we have gestational diabetes, which appears during pregnancy and usually resolves after delivery, but increases the risk of developing type 2 later in the life. And in secondary diabetes, which can result from other medical conditions or drugs, for example, Cushing syndrome, pancreatitis, or prolonged use of steroids. So these types help us appreciate that the duration, control, and mechanism of diabetes influence the severity of ocular complication. Before focusing on the eyes, let's remind ourselves of the systemic impact of diabetes. So we can divide its complication into two main groups, microvascular and macrovascular. So microvascular complication includes retinopathy affecting the small blood vessels in the retina, nephropathy which damages the kidney, and neuropathy which affects the peripheral and autonomic nerves. So these occurs due to the long-term damage to tiny blood vessels and are responsible for many chronic diabetic problems. So macrovascular complications, on the other hand, it involves larger vessels and include coronary artery disease, cerebrovascular disease leading to stroke, and peripheral vascular disease, which can cause ulcer or even gangrene. The reason we emphasize this slide is to understand that the same vascular pathology happening systemically is also occurring inside the eye. The retina in particular gives us a visible window into this microvascular damage. Now let's look specifically at the structures of the eye affected by diabetes. First is retina, the most commonly affected, leading to diabetic retinopathy, which is one of the leading causes of preventable blindness worldwide. The lens undergoes metabolic changes that accelerate cataract formation, often occurring much earlier than in the non-diabetic patients. Then the cornea becomes less sensitive and heals more slowly, predisposing to recurrent erosions and infection. The optic nerve may suffer from ischemic changes, ischemic damage, leading to optic neuropathy. And finally, the extraocular muscles can be involved through cranial nerve palsies, leading to diplopia, restricted restricted ocular movement. So in a diabetic patient, every layer and structure of the eye can be affected from the surface to the retina and to the optic nerve. So let's understand the pathophysiology of the diabetic eye disease. The underlying mechanism involves a series of vascular and metabolic disturbances triggered by chronic hyperglycemia. Firstly, endothelial dysfunction occurs. The walls of capillaries in the retina become thickened, and pericytes, the cells that support these capillaries, are lost. This weakens the vessel wall, leading to leakage and microaneurysm formation. Secondly, there is capillary occlusion and hypoxia. When the small vessels get blocked, parts of the retina become deprived of oxygen. This hypoxia stimulates the release of vascular endothelial growth factor or VEGF, which is a key mediator in the development of neovascularization, which is the hallmark of advanced diabetic retinopathy. However, these new vessels are abnormal, fragile, leading to hemorrhage and further damage. Additionally, oxidative stress and inflammation contribute to the breakdown of the blood-retinal barrier, leading to significant macular edema and progressive vision loss. In short, the combination of leakage, occlusion, neovascularization, and inflammation forms the pathophysiologic basis of diabetic eye diseases. Now that we have understood the underlying mechanism, let's list the major ocular manifestation we see in diabetic patients. First is diabetic retinopathy. Again, it is divided into non-proliferative and proliferative form. Then second is refractive changes due to fluctuation in blood sugar levels, lens changes such as early cataract formation, iris and pupil changes such as rubeosis iritis and subsequently develop neovascular glaucoma. Then cornea, it leading to diabetic keratopathy and optical nerve involvement, including diabetic papillopathy and ischemic optic neuropathy. And lastly, cranial nerve palsies, especially third, fourth, and sixth nerve, leading to diplopia. Each of these will be discussed in detail as we move through the next slides. So, most significant ocular manifestation of diabetes is diabetic retinopathy. This is the leading cause of preventable blindness among working age adults worldwide. It occurs in both type 1 and type 2 diabetes, and its risk increases with the duration and poor control of blood sugar. The basic underlying problem, as we just discussed, is microangiopathy, that is damage to the small retinal blood vessels. Over time, this damage leads to leakage, ischemia, and eventually neovascularization. So broadly, it is classified into two stages, non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. So in NPDR, the changes are confined to the existing retinal vessels. There is no new vessel growth at this stage. The earliest sign is the formation of microaneurysm, tiny circular outpouchings of capillary walls caused by pericyte loss. They appear as small red dots on fundus examination and are best seen in the posterior pole. As the disease progresses, we see dot and blot hemorrhages due to ruptured capillaries. These are usually located in the deeper retinal layers. Next, we notice hard exudates, which are yellowish lipid deposits that form as plasma leaks from damaged vessels. They often cluster around the macula and may indicate macular edema. We can also see cotton wool spots, which are small white patches representing localized retinal ischemia, specifically nerve fiber layer infarcts. Depending on the severity, NPDR can be further categorized as mild, moderate, or severe. So mild NPDR shows only microaneurysms, moderate shows hemorrhage, exudates, and venous bleeding, and severe NPDR, the famous 4-2-1 rule, that hemorrhages in all four quadrants, venous bleeding in two or more quadrants, or intraretinal microvascular abnormalities in at least one quadrant. So key point is that NPDR represents early damage, and if detected at this stage, vision can often be preserved with good systemic and ocular management. So coming to the proliferative diabetic retinopathy, when retinal ischemia becomes severe, the hypoxic retina releases large amount of VEGF. This stimulates the growth of new and abnormal blood vessels, a process known as neovascularization. These new vessels can appear at the optic disc or elsewhere on the retina. Unfortunately, these vessels are fragile and easily ruptured, causing vitreous hemorrhage. Over time, fibrous tissue accompanies these vessels and may contract, leading to tractional retinal detachment, which can result in permanent vision loss. Neovascularization can also occur on the iris, a condition called rubeosis iridis, which may lead to neovascular glaucoma due to blockage of the trabecular meshwork. So in short, NPDR is vascular leakage and ischemia. PDR is neovascularization and scarring. Once the disease reaches the proliferative stage, the risk of severe visual loss increases if not treated properly. Now, another important manifestation is diabetic macular edema, which can occur at any stage of the retinopathy. Is diabetic macular edema, or it is caused by the breakdown of the inner blood retinal barrier leading to accumulation of fluid in the macula. It is primarily driven by a VEGF mediated leakage from retinal capillaries. Clinically, patient complains of blurring of central vision, difficulty reading, or distortion of images, while peripheral vision may remain intact. On fundus examination, you may see the thickening of macula, microaneurysm, hard exudates arranged in a succinate pattern around the fovea. It is now considered one of the most common cause of visual impairment in diabetic patients and requires specific treatment, including anti-VEGF injections or focal laser, depending on the pattern. Now, how do we evaluate and document diabetic eye disease? The first and most essential step is dilated fundus examination using slit lamp or with indirect microscopy using 90D lenses or 20D lenses. This allows detailed visualization of posterior pole and mid periphery. Fundus photography nowadays is extremely valuable for documentation and follow-up. So serial photographs helps to assess the disease progression and response to the treatment. OCT is to quantify basically the macular thickness and detecting macular edema. It provides high resolution cross-sectional images of the retina. Then fluorescein angiography, which helps to identify the areas of capillary non-perfusion, microaneurysms, and neovascularization. It also helps to differentiate focal from diffuse macular edema. So together, these investigations form the backbone of screening, diagnosis, and management planning for diabetic retinopathy. So coming to the next is refractive changes. Apart from its effect on the retina, diabetes can also cause refractive changes in the eye, and this is something we often see in our day-to-day practice. Fluctuating blood glucose levels lead to changes in the hydration and refractive index of the crystalline lens. When blood sugar rises, excess glucose enters the lens and is converted into sorbitol through the aldose reductase pathway. Sorbitol causes osmotic swelling of the lens, which temporarily alters its curvature and thickness. This usually results in a transient myopic shift, meaning the patient becomes more nearsighted. Some patients may suddenly complain that their distance vision has become blurry, but near vision has improved, as we have seen in the cataract patients. Once blood sugar stabilizes, the swelling resolves and the refractive error often returns to baseline. That is why before prescribing a new glasses to diabetic patients, we must always ensure that their blood glucose is under good control. Otherwise, the refraction might change again within days or weeks. So the key clinical point here is always check the patient's glycemic control before performing refraction or prescribing lens. So coming to the lens changes in diabetic patients, the lens is particularly vulnerable to the metabolic effects of diabetes. High glucose levels lead to glycation of lens proteins and sorbitol accumulation, which in turn causes lens opacification. This explains why diabetes often develop cataract at a much younger age than non-diabetics. There are few characteristic types of cataract seen in diabetics. First is snowflake appearance, which is commonly seen in young type 1 diabetics, which is characterized by grayish white subcapsular opacities resembling snowflakes-like appearance, often developing rapidly when blood sugar is poorly controlled. Second is posterior subcapsular cataract, which is very common in both type 1 and type 2 diabetes. It tends to affect near vision first and causes glare, especially in bright light. And third one is cortical and nuclear sclerosis, may also develop earlier in diabetics due to oxidative stress and protein denaturation. So, in practical terms, when a diabetic patient presents with early cataract, it is not just an age related change, it is often a sign of poor metabolic control. Therefore, before planning cataract surgery, always ensure that blood sugar and HbA1c levels are optimized to reduce the risk of post-operative infection and delayed healing. Now let's discuss changes involving the iris and pupil. The most important condition here is neovascularization of iris, or also known as rubiosis iridis. This happens when proliferative diabetic retinopathy leads to severe retinal ischemia. The hypoxic retina releases VEGF, which diffuses into the anterior chamber and stimulates new vessel formation on the surface of the iris. These new vessels first appear around the pupillary margin and later spread to the angle of the anterior chamber. The condition is not just a cosmetic issue, it can be sight-threatening. So when these vessels invade the angle, they can obstruct the trabecular meshwork leading to neovascular glaucoma. This is a very painful form of secondary glaucoma, often associated with high intraocular pressure and poor visual prognosis. So if you see a diabetic patient with rubiosis iridis, urgent referral to a retinal specialist is needed for PRP laser or anti-VEGF therapy to reduce basically the vascular endothelial growth factor levels and control neovascularization. Now coming to the corneal changes, cornea is another structure affected by diabetes, though its involvement is often overlooked. Due to autonomic neuropathy and reduced corneal sensitivity, a condition called neurotrophic keratopathy, the corneal epithelium becomes more fragile. As a result, diabetics often experience delayed epithelial healing, recurrent erosions, and are more prone to infectious keratitis. We also see superficial punctate keratitis and increased risk of post-surgical epithelial defects, for example, after cataract or refractive surgery. So these changes occur because of abnormalities in the corneal nerves, reduced tear secretion, and damage to epithelial basement membrane adhesion complexes. From a clinical point of view, always handle diabetic corneas with extra care during contact lens fitting or surgery. Encourage proper lubrication and ocular surface protection. Avoid topical medication that delay healing, such as long-term preserved drops. In short, the diabetic cornea is more fragile and slower to recover, so attention to surface health is very important. Now let's move deeper to the optic nerve, which can be affected in several ways. One entity is diabetic papillopathy, a mild transient optic disc swelling seen in diabetic patients. The exact cause is unclear, but it's thought to be due to microvascular ischemia at the optic nerve head. Patients may have mild visual blurring, and the condition usually resolves spontaneously over weeks to months. Another more serious condition is ischemic optic neuropathy, especially non-arthritic anterior ischemic optic neuropathy. Here, the blood supply to the optic nerve head is compromised, leading to sudden painless loss of vision in one eye. Fundus examination shows a swollen, pale optic disc with altitudinal visual field defects. So diabetes, hypertension, and dyslipidemia are major risk factors for non-arthritic anterior ischemic optic neuropathy. Since the optic nerve is a purely vascular structure with little collateral circulation, even a small ischemic event can result in significant, often irreversible visual loss. Now coming to the clinical management strategies. Now we have understood the wide range of ocular complications caused by diabetes. Let's move on to how we manage these patients clinically. Managing diabetic eye disease is not just about treating the eye, it's about treating the patient as a whole. This requires a multidisciplinary approach involving ophthalmologists, optometrists, physicians, and endocrinologists. Let's look at some key strategies. First is regular eye examination. Every diabetic patient should undergo a comprehensive dilated fundus examination at least once a year. For patients with known retinopathy, more frequent follow-up may be needed. Modern image techniques such as fundus photography and OCT are extremely valuable for documentation and monitoring progression. So optometrist plays a major role in early detection through the screening programs. If you detect any sign of diabetic retinopathy, even mild NPDR, it's important to refer the patient to a retina specialist immediately. Early referral allows for a timely intervention before irreversible vision loss occurs. So the cornerstone of the management remains tight glycemic control. Aim for HbA1c should be less than 7%, along with optimal control of blood pressure and cholesterol. So lifestyle changes such as balanced diet, regular exercise, weight management, and avoid alcohol, smoking all have significant impact on ocular outcomes. So we must also educate patients about the importance of regular eye checkup. Organizing diabetic eye camps, public talks, or awareness driven can help identify understanding this condition and prevent blindness on a community level. In short, management is not just about what we do in the clinic, it's also about how we educate and motivate patients to take charge of their condition. Coming to the pharmacologic therapy, when medical treatment is required for diabetic retinopathy or macular edema, we now have several effective pharmacologic options known as anti-VEGF agents. These drugs inhibit the vascular endothelial growth factor and reduces the abnormal vessel leakage and neovascularization. So commonly used are ranibizumab, aflibercept, and bevacizumab. These are administered as intravitreal injections, usually given monthly or at longer intervals depending on the response. They have become the first line treatment for diabetic macular edema and proliferative retinopathy in many cases. In addition to anti-VEGF drugs, we can also use corticosteroids, which reduces inflammation and vascular permeability. Commonly used options include IVTA, dexamethasone implant. However, these steroids basically carry a high risk of increased intraocular pressure and cataract formation. So they are used generally selectively. So in short, pharmacologic therapy helps to stabilize or improve vision, but it needs to be combined with strict systemic control and regular monitoring. So coming to the laser photocoagulation, before anti-VEGF therapy became popular, the laser photocoagulation was the main treatment for diabetic retinopathy, and it still plays an important role today. Basically, there are two types of the laser treatment. First is focal and other one is panretinal photocoagulation. So focal or grid laser used mainly for diabetic macular edema, the laser seals leaking microaneurysms and reduces macular swelling. Panretinal photocoagulation basically used for proliferative diabetic retinopathy. These multiple laser burns are applied in the peripheral retina to reduce ischemic drive and suppress VEGF production. This in turn causes regression of neovascularization and lowers the risk of vitreous hemorrhage. Although patients may experience mild side effects such as reduced night vision or peripheral field loss, the panretinal photocoagulation remains one of the most effective tools for preventing blindness in proliferative disease. Remember, the laser works best when done in the earliest stage, before tractional changes or vitreous hemorrhage occurs. Now, in advanced cases where vitreous hemorrhage or tractional retinal detachment has already occurred, surgical intervention becomes necessary. The main surgical procedure used is pars plana vitrectomy. In this procedure, the vitreous gel is removed to clear hemorrhage and relieve traction on the retina. Any fibrovascular membrane are carefully dissected and endolaser photocoagulation can be applied intraoperatively to prevent the recurrence. Vitrectomy can significantly improve visual outcomes in advanced diabetic eye diseases, but it's a complex procedure and best avoided through early detection and treatment of retinopathy. As an optometrist and ophthalmologist, our goal should always be early diagnosis to prevent the patient from reaching to this stage. So most important is patient education. We can treat the disease, perform surgeries, and give injections, but unless patients understand their role, long-term success is difficult. So here are some key messages we must communicate to every diabetic patients. Maintain optimal blood glucose, blood pressure, and cholesterol levels. These three parameters go hand in hand when it comes to protecting vision. Have annual dilated eye examination. Even if there are no symptoms, many patients lose vision silently because early retinopathy is asymptomatic. Report any sudden changes in the vision immediately, especially floaters, blurring, or distortion of the images. Follow a healthy lifestyle with a balanced diet, regular physical activity, and complete smoking cessation. Avoid self medication or skipping follow up appointments. Consistency is the key for treatment of the diabetes. So, encouraging this proactive attitude can dramatically reduce the blindness rate from diabetic retinopathy. As a clinician, we must serve not only as caregivers but also as educators and motivators for our patients. So, let's summarize the key point from today's topic. Diabetes is a systemic disorder that affects every part of the eye from the cornea, lens to the retina and optic nerve. Diabetic retinopathy remains the leading cause of preventable blindness among working age adults. The main underlying mechanism are microvascular damage, ischemia, VEGF mediated neovascularization. Early detection through regular screening is the best way to prevent visual loss. Strict control of blood sugar level, blood pressure, and lipids is equally important as ocular treatment. Anti-VEGF therapy, laser photocoagulation, and vitrectomy have revolutionized management and improved outcome dramatically. Finally, the patient education and interdisciplinary care are the cornerstone of long-term success. If we remember just one message from this session, it should be diabetic eye disease is largely preventable, but only if detected and treated at earlier stages. So, thank you so much. Thank you all for your attention and participation. I would like to extend my sincere gratitude to the Optometrists Federation of India for giving me this opportunity to share my insights on ocular manifestation of diabetes. It's an honor to be part of an initiative that promotes learning, collaboration, and excellence in eye care. Thank you so much for inviting me.
Thank you. Thank you so much, sir, for the wonderful talk. I know it was a very vast topic, but you completely gave justice to the topic and finished it in time. So, thank you so much. If participants have any questions, they can put them in the chat box. Sir, I would like to ask you one question that, as you said, the early diabetic retinopathy is asymptomatic and, as a part of an optometrist community, we are the primary healthcare providers, and patient first comes to us. So what are
Yes.
the earliest detectable clinical signs of diabetic retinopathy an optometrist should watch for during the routine screening process?
During the routine screening process, basically change in the refraction, that is first thing, and early cataract development. That may be the earliest sign.
Okay.
But once we see the retina, we know the exact condition of the exact stage of the diabetic retinopathy because it is totally a painless thing.
Right. Yes.
When the symptoms appears, it is already progressed to advanced stage.
Yeah. Okay, and another question is, what are the communication strategies, work best when you're counseling or explaining the diabetic eye
Yeah,
disease to patients who have no symptoms at all, but still they are at the high risk?
yeah, that is the main
Yeah.
communication that, yeah, that is the main thing.
Yes. Any questions from the participants? They can put them in the chat box. I think we have, okay, one question is, okay, this question came before you started for the corneal changes. So how do refractive changes impact contact lens fitting and comfort and corneal physiology in diabetic wearers?
No, basically, there is reduced corneal sensation in diabetic patient. That is why contact lens fitting is affected.
Okay,
There is chances of epithelial erosion in such cases.
okay,
So
so,
better is to avoid contact lenses in such patients,
okay,
mostly in advanced diabetics.
okay. Another question is, why does the refractive error fluctuates? What is the,
That I already explained. That is due to the lens changes.
right?
As mainly diabetes causes the protein loss from the all over the body. So our lens is made up of protein. So there is protein loss. So formation of the cataract is there. That's why the myopic shift is occurs, lens changes occurs, basically.
Okay. Okay, another question is, in a patient with good HbA1c control but rapidly progressing retinopathy, what systemic or ocular factors should be investigated?
First, do OCT and if needed, fluorescein angiography to know the exactly the area affected due to the ischemia.
Okay. Okay, any other questions from the participants? Okay, sir, I would like to ask you that how do you see the role of optometrist evolving in long term, when it comes to the monitoring of diabetic patients?
Yeah, optometrists are the main playing key role in these patients basically. But first, patient sees the optometrist only, then they comes to us.
Right. Yes.
So mainly creating awareness and patient education is most important. And important part is counseling.
Yeah.
That even if patient feels there is no symptom, the patient should undergo the dilated fundus examination at least twice in a year.
Hmm. Yeah, so timely referral is the key
Yes,
actually in
is the
these.
key.
Yeah. Okay, we have another question. What is your opinion regarding screenings? How can we sensitize patients that screening can be the only way to find out?
So arranging basically camps, diabetic camps, and we have now the advanced modalities of fundus photos and all. We can easily detect we can with mass, if we can detect it in communication.
Right, yeah. And nowadays we have
We
handheld,
can plan mass screening also in the camp.
yes. Okay.
So
Any other
even if
question?
the dilatation is not possible, we have all those modalities to find out the undilated, we can take undilated fundus photos in
Yes,
such patients. And we can detect the earlier changes in the retina.
correct. Yes. Okay. Any other questions? We have few minutes. Meanwhile, I would like to show you the IEC poster which we have made in the honor of Diabetic Eye Disease Awareness Month. So November is celebrated as the Diabetic Eye Disease Awareness Month, and that's why we have conducted this session. And the part two also will be coming, which is on 28th. So where we will discuss the multimodal imaging in the diabetes right from OCT interpretation, fundus imaging, and everything. So that session is an upcoming session in the November. So please stay tuned for that. OCI develops IC materials every month. So this month we have diabetic, eye disease awareness poster. Let me just give me 1 minute. I will share it with you all. Is my screen visible? Anybody can type it in the chat box or
Yes,
can you all
Bhushan.
see the poster?
Yes, Asha.
Poster, yes, thank you. Thank you so much. So this is the IC poster. We have kept a space for your practice logo. You can put your practice logo here and display it in your waiting room or in clinics, wherever you want to do it. It is freely downloadable, but only available for OCI members. It's available on our website, and even through emails you'll be getting it. So stay tuned for the part 2 session. We have one more question actually. Hello, sir. Most of the patient came with high diabetes, and when we counsel them for disadvantages of high diabetes, so they are literally smiling and let it go. So how do we convince them? Yeah,
It is a
it's
major
actually
task.
a scenario.
It is very difficult to convince the patients.
Yeah. So any strategies to convince them, maybe from your experience? Or...
Show the different clinical images to the patients, like what appears in the advanced stages. Just
Right.
show them. That might be one of the key factor in the counseling.
Yes.
That this is the normal retina and this is the affected retina. There may be chances of sudden loss of vision or complete loss of vision. Then might be patient
It's
know the
difficult.
importance of the diabetes.
Right. Okay. Okay, I think no more questions from the participants. So thank you, sir, for taking the time to share your knowledge with
Thank you
us
so much.
and for contributing to our World Diabetes Day
Thank
initiative.
you so much.
For sharing such valuable knowledge, practical perspectives, and of course the guidance. And your contribution truly enhanced our understanding of how diabetes affects the eye, and how we as eye care professionals can play a role in early detection and prevention of the vision loss. So thank you so much. Thank
Thank you
you
so
for
much.
participating, everyone.
Thank
The
you. Thank you
session
so much.
is free and freely available on our YouTube channel. It will take 2-3 days to upload it. After that, you can access it freely. Thank you. Thank you so much.
Thank you so much. Thank you.